Hello, Razorbacks. It's such a pleasure to be with you all this evening. In 2019, African and African American Studies celebrated the 50th anniversary of our program being on this campus. And in the spirit of Sankofa, we've had the opportunity to reflect on the past and to honor the legacy of many visionary unsung heroes and pioneers who have paved the way to create the kind of rigorous interdisciplinary program that we currently have. The kind of program that promotes academic excellence, critical thinking, and all that. We therefore invite you to come over and study with us, pick up a major or minor in African and African American studies. Now, one of the features of the program that we're especially proud of in African and African American Studies is our lecture series that features a diverse range of lectures and academic talks by a variety of scholars. We bring to campus a wide range of folks in academia and in the community who are doing great and exceptional work. And in the past, we've featured the likes of Dr. Alan Morris, who looked at the scholar-denied W.E.B. Du Bois and the birth of modern sociology. Dr. Carol Anderson, the author of White Rage, who gave a lecture on 1 year later, Where We Now, and the cultural context leading up to the 2016 presidential election. Nicole Hannah-Jones, who created the 1619 Project, who gave us a lecture on understanding modern day segregation. And Kaisi Lemon, who was the winner of the Andrew Carnegie Medal for Excellence in Nonfiction, who gave a talk on his book, Heavy. Now, our keynote lecturer follows this long line of exceptional speakers that we've had in African and African American Studies. A scientist from the Centers for Disease Control and Prevention, Dr. Ernest Yufenyuy, who will be speaking to us about containing contagions, the overlapping pandemics of HIV, COVID-19, and the global Black community. Now, Dr. Yufenyuy and I met over 13 years ago playing intramural soccer at Vanderbilt University one summer. And if he was not on the soccer field, 9 times out of 10, he was in his lab. So when we found ourselves in a pandemic last year with the CDC at the helm, I was not tripping at all. I felt a sense of calm and security because I knew he, even though this was not his specific area of specialty, his calm and brilliance would be a part of the organizational effort to tackle this disease. Now, Dr. Yufenyuy graduated from Vanderbilt University in 2014 and went on to become a reputed voice in HIV/AIDS research, the other pandemic that hit us some 40 years ago, hitting the continent of Africa, which he hails from, and the diaspora community especially hard. And it is in this space that he spends most of his time and his energy. Dr. Yufenyuy has over 15 years of experience in infectious diseases and more than 6 years of international experience in health policy formulation and implementation with a focus on global HIV and other infectious diseases. He has collaborated widely with experienced and world-renowned public health institutions globally. So Dr. Yufenyuy's research includes all aspects of HIV prevalence, incidents including detection, characterization, serotyping, surveys, and helping us tackling the disease by developing new and novel detection methods to help advance the field. He is responsible for providing laboratory and public health policy advice and planning in the direction and coordination in the diagnosis of HIV prevention and detection. Now, Razorbacks, here's what's in it for you. And I mean, we're in for a treat tonight because of the unique nature of Dr. Yufenyuy's upbringing, growing up in the West African nation of Cameroon and coming of age at the height of the HIV pandemic, and being so inspired that he would go on to dedicate his research and his life's work to studying this virus. Then COVID-19 arrived at the tail end of 2019, and I imagine, like everyone else at the CDC, he had to pull his weight as they sought to assemble a team like the Avengers to address this virus. So this talk tonight, at the intersection of his work in containing HIV and with this current crisis that we're experiencing, is informed indeed by firsthand experiences, extensive research, and work in virology, and dare I say, great passion. And given the effects of COVID-19 on the Black community, it is my hope that Dr. Yufenyuy's expertise, which is relevant to many parts of the university ecosystem and this local community, from public health to medicine to global health, will stimulate some much needed discussion in both the community and university campus. We're lucky in African American studies because this effort today is fortunate to have the collaboration of various organizations such as the Pat Walker Health Center, the colleges of engineering, honors college, departments of biology, history, English, the offices of Walton College of Diversity and Inclusion, the programs in medical humanities, the office of the Vice Provost of Diversity and Inclusion, Fulbright College, Office of Diversity and Inclusion, and many other support from many other team members, including Mr. Hughes, our program assistant, and Sinitra Hughes, who has been our tech guru. These lectures are free and open to the public, and we thank you for being here. And I will now turn it over to Dr. Yufenyuy.
Wow. Dr. Banton, what an introduction. Thank you so much for the opportunity to be here tonight. And listening to Dr. Banton introduce me, it sounded like she was talking about somebody else, but it's very much appreciated to hear a friend from very many years ago talk so highly about me, so I very much appreciate it. So tonight, I will be talking about containing contagions and the overlapping pandemics of HIV, COVID-19 in the United States here, and of course, globally. So I don't take this for granted. I really appreciate this invitation. And ever since I got here yesterday, I've been treated like a king, really. So I very much appreciate that. And thanks again, Sarah. Thanks, Dr. Banton, for all your hospitality. And the folks that I met with last evening, Dr. Bailey and the crew, thanks very much for that warm welcoming. So I want to really, start by putting a disclaimer here, really, that I do work for the Centers for Disease Control and Prevention. But what I always want to start by saying, really, is that I'm not here on an official mission that is sponsored by the Centers for Disease Control. So what I say, I'm very much responsible for it and does not represent the official view of the Centers for Disease Control. However, everything that I share with you tonight, this is data that is, most of it is coming from the Centers for Disease Control and Prevention. So it's data that is very authentic and it's data that is validated. So I haven't said that, is it projecting already?
Not yet.
Okay.
Share screen.
Oh, share my screen. All right, so I'm sharing the screen.
The
Next one. Share. All right, so I would like to start with, looking at, let's see, try to, okay, navigate this. looking at the biology of the two viruses. So I will not be doing myself any favor if I come to a talk like this and I don't say anything about the biology of the viruses. So this is a slide that talks about that biology, and I promise you this is the only biology that you will hear tonight. So when it comes to the HIV virus, it is a retrovirus that attacks the immune system. Its genetic material is RNA and must be converted into DNA during replication and then integrated into the host genome. Once it integrates, the host continues to make more of the virus, makes more of the virus, and over time, the immune system is actually fighting that virus as well. Over time, the immune system will give up, and this is when the individual will then advance to the 8th stage, which is the acquired immune deficiency syndrome. So for HIV, it is transmitted by sex, by blood transfusion, perinatally, and by needle stick, and some other common ways that you may be familiar with. And then, of course, the COVID, which is SARS-CoV-2. So just to mention here that SARS-CoV-2 is the virus that causes COVID-19. So it is a positive single-stranded RNA virus. Its genetic material, RNA, is translated and processed to proteins forming the viral replication and transcriptional complexes. And from here, it continues to make more of the virus, makes more of the virus, and causes, the symptoms that we normally see and feel, much like the common cold, flu, and pneumonia. It is very contagious, as you know, and quickly spreads through air by coughing, sneezing, close personal contacts, touching, nose, mouth, eyes, etc., and the many ways that you've definitely had. So one of the things that I want to mention here too is the time frame, that the individual transitions from being HIV positive to being AIDS, to arriving at the 8th stage, which could range anywhere from 6 or 5 years to 10 years, as compared to SARS-CoV-2. When you get infected, you're looking at a matter of days before you start expressing the symptoms that you normally see. And now, since, again, this is a history series, I will not be doing any favor to all of you if we don't look at this historically too. So the story all started with HIV in the summer of 1981, when the CDC reported 5 young men in Los Angeles with pneumocystis pneumonia. Now, back then, you could only see this pneumocystis pneumonia in individuals that were immunocompromised and probably resulting from having cancer of some sort. And then following that June report in 1981, in July, the CDC again published in the MMWR reports of Kaposi sarcoma in 26 homosexual men in New York and California, and named it GRID, which is a gay-related immunodeficiency. Now, out of this 26 homosexual, just to mention here that 25 of them were white men and only 1 was a black man. So by December of 1981, by that year end, you had a total of about 337 cases of HIV, and then of AIDS, of course, at the time. And then out of those, a lot of people had died by that year ends as well. 130 people had died by year end of 1981. Now, just to mention here that, from that 1981 to 1984, we did not know anything about the virus, and the virus was identified only in 1984 as the causative agent of the AIDS that was being seen in this gay young men. It took until 1987 before our then president, Ronald Reagan, actually mentioned HIV illness for the first time in the United States. So that is 6 years after the disease was first noticed. And it took it took somebody that he knew that died before he actually publicly mentioned this. So by then, we already had about 60,000 cases in the United States and 28,000 deaths. So one of the things that you then notice here is denial when you are faced with something that is unknown, like this type of a virus. And then coming SARS-CoV-2 in 2019, its story began in December in Wuhan, China, when they reported dozens of cases of pneumonia of unknown cause. Now, it took only about 2 weeks for SARS-CoV-2 virus to be identified as the cause of the unknown pneumonia. So by the second week of January in 2020, The first case outside of China was noticed in Thailand. And then by the third week of January in 2020, the first case was reported here in the United States in the state of Washington. By the 30th of January, the WHO declared the outbreak as a public health emergency of international concern. And then during the first week of February, the first death was reported here in the US soil. Now, by the second week of March, that is when the WHO actually declared it as a pandemic. Now, if you look at what had happened between the January or the December 2019 to the March 2020, one of the things that we noticed, and even as we continue to have more cases, up to about 5 million cases and even tens and thousands of deaths, one of the things that you will notice is that there was still denial, just the same way as there was denial when we had HIV back in the 1980s. So there was political rhetoric was very dismissive of anything. This will go away before you notice it. It is a hoax. It is a Kung flu, and so on and so forth. So language like this did not really help, and understandably so. I know this was a new virus that nobody knew anything about it. But again, denial becomes a defining statement at the time when you are facing this type of things. Now, one way to actually look at the magnitude of some of these problems when it comes to an epidemic or pandemic is actually to do a quick Google search. And if you were to do this for the HIV and the COVID-19, what you realize is that we have numbers here in trillions. You have numbers here in trillions compared to our common flu, which you have here, some in trillions too, but the magnitude is definitely smaller than the one that you see with the COVID-19 and HIV. What that tells you is that this is of great concern to a lot of people, and they're definitely searching for this every day, every hour, every second. Now, if you were to look at the statistics worldwide, what you realize, these numbers have definitely changed since I put this a few days ago. You realize that worldwide, we have more than close to now 250 million cases of COVID-19. And out of those, close to 5 million deaths have been reported for COVID-19. Now, when it comes to vaccination, you realize that we've vaccinated barely 3 billion people for COVID-19 compared to the 7+ billion people that we have in the world. And if you look at this, these vaccinations, how the percentages are compared, you see that the majority of the countries that have high vaccination rates are those that are high-income countries. Therefore, vaccination trends do follow income lines. And if you compare low-income countries like the ones in Africa, you see here that the vaccination rates are very, very low. Where Africa, compared to the rest of the world, only stands at about 3.5%. 3.5% of the population has received at least one dose of the vaccine. Now, if you look at this, you look at the top countries that are showing our vaccinations against COVID-19, you again see here that we here in the United States, we're probably ranking way down here. I don't know what number is, but here at 66%, where this 66% of the people have received at least a single dose of the vaccine. Now, if you look and compare this with, again, the African countries, some of the African countries that have actually featured on this chart, you see that most of them, starting from South Africa, which is the only country that has a significant percentage of people vaccinated at 26%. When you see countries like Kenya, Egypt, Ethiopia, Nigeria, and Tanzania, they all have less than 10%. And what that is telling you is that for the rest of the African countries, this is just a few out of the 54 African countries. So most of them really are not really featuring or haven't really been vaccinated at all. So that tells you again, like I mentioned earlier, that it follows income lines internationally. Now, coming home in the United States, you see a different trend where you see it follows actually ethnic lines, where the majority of the people who have at least one dose administered to them are white, compared to the contributions of their percentage to the total population. So they've received the highest dose, the highest number of vaccinations, compared to the Black and the Hispanics, who have received comparatively, a smaller dose or percentage, or they contribute a smaller percentage to the people who have been vaccinated. So I'm going to switch gears here a little bit and focus maybe on HIV for the next couple of slides. And partly so because one can argue that what we are seeing with the COVID-19, for instance, is just COVID has been around for only about a year and a half. So it has not been tested by time per se. So I can focus on HIV for a little bit, which has been tested by time, so that you see, okay, are the differences that we are seeing across the different countries or across the different ethnic groups within the United States, do those have those, since those have been tested by time, do they still stand as well? So that is where I want to focus on the next couple of slides. So if looking at this slide here, this is a summary slide that looks at the global HIV epidemic as of 2020. And just to mention that as of that 2020, we already had more than 80 million people infected with the virus since it was first discovered in the 1981. And out of those, more than 36 million have actually died from the virus. Now we have 37.7 million people living with the virus as of 2020. And then in 2020, 1.5 million people were newly infected with the virus. And then 680,000 people died from the virus as well. Now, so what this means, this is actually showing that we are not anywhere close to having epidemic control, because epidemic control is being defined as when you have the number of new cases actually less than the number of deaths. In this case, we are not anywhere close, although the target that the UNAIDS had set a few years back in 2015 was that by 2020, we should be having maybe less than 500 new cases a year globally. But having 1.5 million, it shows that we are not anywhere close to those numbers. Now, these numbers here just further break down what I've shown here in the red, which looks at the distribution by age group and distributions by gender. So again, the UNAIDS published this a few years ago, looking at the top 30 countries that actually account for 89% of new HIV infections globally. And what you do notice here is that it's constituted of low and middle income countries, and then high income countries, just two of them, where the two high income countries represented here are the Russian Federation and the United States of America. Now, one thing that I want to mention here is that the majority of these countries, 18 of them out of the 30, are all located in sub-Saharan Africa. So you have 30 countries that are contributing to about 89% of all new HIV infections. So this is a high number that shows that if we were to do some focus or targeted response, we should definitely be looking at these countries, since they are contributing to the majority of new HIV infections globally. So from what I've already shared with you, it is then no-brainer to say that most of the infections are actually located in sub-Saharan Africa. So out of those 37.7 million people that I showed in the previous slide that are living with HIV, I think 27 million of them are actually coming from sub-Saharan Africa. So the majority of HIV infections are therefore in this sub-Saharan Africa. So growing up in this part of the country or part of the world, really, it was not very, very uncommon to see signs like this one that was we saw in Zambia, where it's telling that you are either affected or infected with HIV/AIDS. So growing up in that region, you knew people who were HIV positive. They were your friends, they were your neighbors, they were your relatives. And so there is no way one could say they were not affected by the HIV or more so infected by the virus. So, and just to mention here too, that you have countries that have very, very high prevalence rates of HIV in their countries, to the point where 1 out of every 3 persons is infected with HIV. So you see that type of rate at a close to 30% prevalence HIV, it is really, really alarming. But the good thing is that most of these countries have actually achieved what we call viral suppression. So they are probably pretty much approaching what we call epidemic control. I will talk about that maybe later on. So I share with you here the title of a book called Man No Be God, which actually translates to Man Is Not God, that describes a medical missionary's mission in Cameroon when the first AIDS cases were reported. In his book, he actually tries to describe the things that he had to go through. And when the virus came around, he actually said there was the arrival of a new enemy in town. And it was this new enemy that a few years later was responsible for the majority of deaths in that hospital, was responsible for the majority of deaths in the town and in the surrounding villages. So he left the country very satisfied given what he had contributed to the pandemic, but still he said man was not God to deal with all the problems that he had to encounter. So I urge you to read that book. I'm not advertising the book, but definitely you can see some information there that will be of importance. Now, what I want to share with you here is how the epidemic is distributed by population, and starting with the sub-Saharan Africa. So what you will see here, for instance, is that the younger women are at risk in Africa comparatively. And let's look at how this breaks down. Here, I'm showing you that females 15 to 24 are responsible for 25% of new HIV infections in Africa, compared to their contribution to total population, which is just at 10%. So what this is saying is that if you look at the African population, you have the 10% of the people in the population are females from the ages 15 to 24. But if you look at the percentage of people who have HIV, the females from 15 to 24 are contributing to 25% of all new HIV infections. So that is really an alarming number, which tells you that this population, therefore, is driving the epidemic as well. Now, let's look at other age groups. Again, females 25 to 49 are contributing to 27% of new infections, compared to their contribution in total population, which is just 14%. And then the third category here are males from 25 to 49, which are responsible for 19% of the new infections, compared to their contribution at 10%. And if you look at Africa, the population really, the way it is distributed, and this is very similar for the rest of the world, really. You have approximately 50% are males and approximately 50% are females. But if you look at, which is shown here in red, really, where the red is the females and the green are the males. But if you look at new HIV infections, you see here that most of it is actually red. So it means that in the African continent, the drivers of the epidemic is really heterosexual and mostly focused on the young women and the young men, as shown by their age groups here. Now, let's take this outside of Africa and see what is happening in the rest of the world. If you look at males here, 15 to 24, they are contributing to 13% of all new HIV infections in the rest of the world outside of Africa, compared to their contribution to population, which is at 8%. But then if you look at that female population, comparing it with what we saw with Africa, you see here that our contribution to the total population outside of Africa is 7%, and their contribution to HIV, again, is 20% here. Oh, no, sorry, their contribution is 7%, meaning that this population actually is not driving the HIV epidemic outside of sub-Saharan Africa. Now, if you look at the male population, which here is from 25 to 49, there are 47% of them, 47% of the new infections are actually coming from this age group, compared to their contribution in the total population at just at 18%. So what this is saying again is that outside of Africa, the mode of HIV transmission is mostly around gay men. So this is the third point here is just combining all this together. But again, you see some of the things that I already mentioned. So the epidemic is distributed differently across the group. And if you start looking at the individual countries, what you also notice is that the epidemic is distributed differently. So coming home to the United States, let's see how the epidemic is actually distributed. So as of 2020, the US had a total of 1.2 million people living with HIV. And the majority of these HIV infections were actually located in the South. In 2019 alone, there were 38,000 infections newly diagnosed in the United States. And the majority of them, 15.2, this is in thousands and in 100,000. So 15.2 were all located in the South. So what that is telling you is that despite the fact that the South only contributed to about 37% of the US population, it it is responsible for more than 50% of all new HIV diagnoses. And it's also contributing to an incidence of close to 47% of all new HIV infections. So we see here that the South is really, when you're looking at it geographically, is the driver of the epidemic here in the United States. Now, the other thing that I want to mention here is that more than 50% of new HIV diagnoses in 2016 and 2017 occurred in only 48 counties. And we know that how many counties are in the United States? About 3,143 counties. But then you have only 48 counties that are actually responsible for 50% of new HIV infections. So the question is, are we really focusing on these counties that are responsible for these infections? So that was looking at things geographically. Now let's look at the new diagnosis by race and ethnicity. This data that I'm sharing with you is from 2019. And if you look at it, look at the Black population, which is leading the chart here, you see that we have 42% of all new HIV infections are actually coming from African Americans, second by Hispanic at 29%, and third by white at 25%. Now let's look at the contribution of these populations or of these ethnic groups to the total population in the United States. The contribution of African Americans to total population is 13% compared to their 42% that they are contributing to all new HIV infections. The contribution from Hispanic, Latino to the US population stands at about 20%, but they are contributing 29% of new HIV infections. And when it comes to Caucasians, white, we know that the contribution to the US population is more than 60%, but they're responsible for 25% of new HIV infections. So you see here that the dynamics are very different when you look at the contributions or their contributions to the HIV epidemic and the contributions to the total population. So Black African Americans and Hispanic people are disproportionately affected by the HIV pandemic. So the Black-white disparity is even more pronounced among women at about 58% of the new infections. When you look at the gender of females, 58% of those are the Blacks, and then 14% are from the whites. So let's look at this then from the standpoint of transmission groups. Again, you see here that when new HIV diagnosis in the US and dependent areas for the most affected subpopulations. So we see here that gay and bisexual men are the population most affected by the HIV. So you see, again, you see Black African Americans, gay men are responsible for the majority of those new HIV infections, again, second by the Hispanic at 7,820, and then third by white MSMs at 5,805. And then looking at it heterosexually, you see here that Black African American females or women are leading the chart, and then second by Black African American men in that number, and then Hispanic Latino women, and then third by white women, white heterosexual women. So again, the conclusion from here is that the drivers of the epidemic by these subpopulations is really gay and bisexual men. So let's look at what is happening here in Arkansas. I decided to throw this in here so that we look at it from our state instead. So in 2018, it was reported that about 5,722 people were living with HIV in the state of Arkansas. And then in that 2018 alone, we had 281 new HIV infections. And then 60 people, actually, it was reported 60 people died from HIV that year. Again, when you have the number of new infections more than the number of deaths from HIV, what that is telling you is that things are not under control. Out of these 281 new infections, 81% of them were from males, therefore mostly MSMs, and then 55.5% were Blacks, and then 38.8% were white, and 8.2% were Latino. Now let's look on the right-hand side and again look at the contribution of all these ethnic groups to the population here in Arkansas. So you see here the white contributes about 75% of the population, and Blacks about 15 or 16%, and then the Hispanics at about 7.2%. Now look at what their contributions to the new HIV infections are. again, what you see here is that the story in Arkansas is not anywhere different from the story that I just shared with you that is happening in the entire United States. So rates of Black males with HIV is actually 4.5 times those of whites. And then when it comes to rates of females or Black females with HIV, that number is 8.4 times those of white females. Now, if you were to look, I took a quick look at a heat map for the state of Arkansas and realized that the majority of these infections were actually coming from Pulaski County. And when you look at other counties, they are pretty much not red at all. What that is saying is that, you know, Pulaski County is the county that has most of these new infections. I don't know the details about the Pulaski County, but some of us who are watching this, and those of you who are on the audience, what you can start asking is, what is really happening in this county that is responsible for the majority of these HIV infections that we see? So what I've shown you so far is, you know, it's very static, where somebody can argue that, well, it's just data from a single year, or 2019 or 2018, as I've shown. But you know, you cannot make any conclusions by looking at just a single time point and saying that, okay, maybe this is that and this is that. So what I really want to share with you now is the evolution of the HIV epidemic in the United States from the 1981 to 2019, looking at the ethnic groups that I've already talked about. So new infections, when you look at it starting from the 1981, what you will appreciate is that new infections were concentrated in the majority white population, as it is shown here on the left-hand side here. And then it peaked at about 1984, 1985, and then started dropping significantly. And then in 1987, it dropped and continued to drop, where now in 2019, it is the lowest. Contrast that with what you see with the Black African Americans and Hispanics, where you see here that for Blacks, it increased, started dropping, reached a placebo, and then stopped there. And then, although it is continuing to drop as we progress in the number of years, but then it remains the highest. Now, just to mention here that in the early years of the epidemic, white people, which constitute about, again, more than 60% of the population, at the time they were contributing about 56% of new HIV infections. That is when you're looking at this time point around here. But then over time, this continued to decrease, and today we are looking at them contributing only about 25%. Contrast that with the Black people, where during the early phase of the epidemic, they were contributing less than 30%, around 28%, but now are contributing more than 40%. And the number stands at actually 43, 42%. The same thing happened with Hispanic, who are now contributing about 29% of our new HIV infections. So what does that translate to when you look at the lifetime risk of HIV diagnosis by race? You see that if you're an African-American man, you have 1 out of every 20 people will have a lifetime risk of HIV no diagnosis. So 1 out of every 20 African-American will be diagnosed with HIV in their lifetime. That's what that translates to. And then 1 out of 48 African-American women, 1 out of 48 Hispanic males, 1 out of 227 Hispanic women, and then 1 out of 132 white men, and then 1 out of 880 white women will be diagnosed with HIV in their lifetime. If you were to look at that, if we were to look at the evolution of the HIV epidemic by the transmission category, remember the first one that we saw was by the ethnic groups. Let's look at it by the transmission category, because remember in the few slides ago, I mentioned that this is being driven by the gay population in the United States. So it has fairly remained the same. You know, here you are looking at a gay population responsible for new HIV epidemics or new HIV infections starting from 1981 to 2019. Although the numbers have decreased significantly, but you look at it, it's still the gay population that is driving the epidemic. There was one time that heterosexual and IDUs actually overtook them, but they quickly maintained their authority in contributing to the total number of new infections in the United States. So what does that translate to when you look at the lifetime risk of HIV diagnosis by transmission group? Again, if you're an MSM in America, 1 out of 6 will be diagnosed with HIV in their lifetime. If you are a woman who injects drugs, 1 out of 23 of them will be diagnosed with HIV in their lifetime. And if you are a man who injects drugs, 1 out of 36 will be infected with HIV in their lifetime. And then heterosexual women, 1 out of 241, and heterosexual men, 1 out of 473. So the other thing that I wanted to mention here too is that now let's look at African-American men or lifetime risk of HIV diagnosis among MSM by race. Now we have narrowed it down to this MSM, but now let's look at it now by race. So if you're an African-American man who is gay, then you stand the chance of 50% to be diagnosed with HIV in your lifetime. And if you are Hispanic, it's 1 out of every 4. And if you are white, it's 1 out of every 11. So again, either way you look at it, whether it is a transmission group or whether you look at it from MSM, from the ethnic group, it's always going to be African Americans leading the chart. Now, before I transition to COVID-19, really, what I've shown is that MSM are actually driving this. But what I did not mention to you, though, is that MSMs only constitute about 2% of the population in the United States. But they are responsible for MSM combined with IDUs, who are injection drug users, are responsible for more than 70% of all new HIV infections. So again, you see that the epidemic is being driven by a particular group which we need to deal with. So what I want to do now is transition really quickly to talking about COVID-19, which you see here that, again, when you look at the cases, that is individuals who are, who have been infected with the virus, the hospitalizations or the deaths, you see here that the ratios, when you compare to white non-Hispanic, you see that African Americans, so American Indians and African Americans and Hispanics, they are several folds, greater than the white population. But for Asian Americans who have comparable numbers in terms of hospitalizations and death, or even have less numbers when it comes to cases, that's why the ratio is less than 1 or less than 1. And then when you look at, this is only showing that Black Africans incur the highest COVID death rates in the United States. Again, this is another study that is summarizing what we showed in the previous slide there. Now, I want to just quickly mention about the reduction in life expectancy that has resulted from this COVID-19 in the United States. What you see here, starting from the 1980s to 2020 and 2021, is that the gap between, whites and Black was actually narrowing with time. But now that COVID has come around, it has actually widened that gap again further. Although you see here that the life expectancy reduces for all ethnic groups, from the white to Black and Latino, the effect has actually resulted into even making the gap in life expectancy wider between the Blacks and between Blacks and whites. And when you look at unemployment rates, again, you see here that the percent of unemployment is really highest with Blacks and Latino when you compare them with the white population. So how do we fight this type of pandemics? And again, I'm going back to HIV to say that this is something that applies to both HIV and applies to COVID-19 as well. So when it comes to fighting and ending any pandemic or any epidemic, the very first thing is to diagnose all people with the HIV or diagnose all people with the COVID-19. And to do that, you have to make sure that there are available tests to do that the tests are simple enough. It cannot just be done in the lab, because if you do it in the lab, then it needs highly specialized hands to actually do the testing. So coming up with rapid tests is very, very important. A test like similar to a pregnancy test, for instance, that anybody can just perform and come up with the accurate results would be really, really important. One of the things too that people mistaken here is that you don't actually wait for things to be perfect before you actually put things into place when it comes to fighting a pandemic like this. You don't want to have a test that is 100% perfect, which you will never actually have a test that is 100% perfect before you deploy it to the population. So having that level of perfection before you deploy things is only delaying and making things more difficult in controlling the epidemic. So once you diagnose all people, then you have to treat the people who are infected. So you treat the people who are infected, whether it is with the HIV, you rapidly treat them. We have treatments now for HIV that are working very well. They have led to viral suppression. Hence, what we have seen that the number of deaths in HIV have significantly reduced over the years. That's why you have about 37 million people now living with HIV and living healthily for that matter. So now when you treat those individuals, now you target those who are the HIV negative or COVID negative, and then put in preventative measures in place to prevent those individuals from actually acquiring the infection, right? Whether it's acquiring the HIV, whether it's acquiring COVID-19, in HIV, we're looking at things here like syringe services. We're looking at things here like PrEP for individuals like in the gay community, for instance, if they are HIV negative and they are the highest risk of being HIV positive. So you may make available to them PrEP so that they can actually take the PrEP and prevent it from acquiring the virus. Whether there are social distancing measures that you have to put in place for, like for instance, COVID-19, whether it's the use of masks, that you have to make masks available maybe for free so that people don't have to buy them, whether it's making condoms available for free so that those who must have the sex must use the condom and prevent it from transmitting the virus. So you make sure that you put these preventative measures in place to prevent those who are negative for the disease to not acquire the disease at all. And then, of course, the last thing here is respond quickly to potential HIV outbreaks or COVID outbreaks to get needed prevention and treatment services to people who need them most. So this is the standard formula to really deal with any epidemic, to deal with any pandemic for that matter. So an epidemic, therefore, is like a raging fire. And what I'm showing you here is a slide that I actually borrowed from my boss, which is showing a fire in California. But what we know about the epidemic, therefore, is that most effective way to fight the fire is to know the leading edge of the fire, right? As shown here on the side. If you come and you are fighting this fire from, let's say, somewhere back there, and look at where the leading edge of the fire is, you have to target it, the leading edge of the fire. But what I've shown you here from the presentation, from the slides that I've already shared with you, is that that leading edge here in the United States is geographically in the south. That's where we have most of the new infections. If you look at it by ethnic group, it is within the Black and African American community. If you look at it by transmission group, it is within the gay population. So the question that we should be asking is, has this been the case? Are we targeting that leading edge of the fire, that leading edge of new HIV cases in the United States? And then, of course, putting prevention measures to interrupt ongoing transmission once we target the leading edge. So what is the critical role of early HIV diagnosis in epidemic control? Because you keep hearing, whether it is COVID-19, whether it is HIV, you want to diagnose people as early as possible, right? You want to diagnose people as early as possible. And I want to share with you this from the HIV so that you see the normal progression that happens with the virus and then decide for yourself whether it makes sense to actually diagnose individuals early on during their infection or individuals late in their infection. So the schematic that I'm sharing with you here shows the progression of HIV from when an individual gets infected to when they actually develop the AIDS. The circles that you see here in the red here is actually showing your chances of transmitting the virus. So where the intensity of the red shows you that here you have the highest chance of transmitting the virus to a negative person. And then of course that intensity actually decreases as you progress to AIDS, which you will still transmit the virus, but your chances of doing so are more diminished than when you were in the acute phase of infection. So during the first 2 weeks of infection, as shown here, the individual is acutely infected. That is, only the viral RNA is present, and then the viral antigens are present. There is no antibodies developed by the body or by the immune system to fight the virus. But then as time progresses, the individual starts making antibodies, but then enters a phase 2, which is defined as the new or recent infection, which is the data that I shared with you, most of the data that I shared with you, saying that new infections in the Africa are coming from African American community, new infections are coming from MSMs, new infections are seen in the South. So those new infections are being captured by this phase here, as defined by this timeline here. And we know that from every data that research that has been shown that more than 50% of the new infections are coming from individuals that are either in these two phases, the acute infection phase or the recent infection phase, compared to the rest of the infection or the chronic infection phase, which is also responsible for 50% of the infections. But look at the time that it takes for them to be responsible for 50% of the infection. It's a relatively very long time compared to this other time frame of acute infection and new infection. So the question is, why is that the case where individuals in the early phase of infection have the greater propensity of transmitting the virus? There are three main reasons. Of course, most of the times when individuals are in this phase, they continue to engage themselves in high-risk behavior, partially because they don't actually know that they are HIV positive, right? The same high-risk behavior that got them infected, they will continue to engage with maybe people who are negative, and then they continue to spread the virus. Also, in the early phase of infection, is characterized by high viral load. So remember, the immune system is not actually, well equipped to fight the virus at the time. So until the immune system starts building up, then it starts reducing that viral load, and that viral burden is reduced. So, and then of course, lifelong transmission potential is increased when you let it go for this long, right? So the individual who is HIV positive and continues to the AIDS stage without any diagnosis, where you diagnose them, but here, so it means that all this while they've been transmitting the virus to their partners or whoever they've been engaged with in whatever activity. So you block if you were able to turn off this tap here, you are actually blocking the chain of transmission moving forward. So let's take a quick look at how the treatments have actually evolved too over time. So in the early 90s, you see here that it was not uncommon for an individual to be on 20 pills of when they are HIV positive. Now compare that to today, where you have individuals actually taking as little as 1 pill per day, delivering multiple drugs. So this work just as effective as 20, if not better, than those 20 drugs that they were taking back then. It looks like this thing is going down. Sorry. So as little as 1 pill per day, delivering multiple drugs. So if you look at, if you were to compare these one drugs with the ones that the 20 plus drugs back then in the 90s, you see that there has been a lot of advancement in the field. The field has really advanced. And as we speak, there are some drugs now that they are in clinical trials that have actually been showing that they may lead people to the stage where they will be taking maybe once every month, taking a pill once every month, or even once every 6 months. So these are called long-acting injectable drugs. So that is where the field is actually taking us. So let's take a look at the vaccination rates among minority populations. And I'm putting all these things here. They appear to be random, but there is a story behind it that I want to build so that we can see where we have failed, and then see what we need to do so that we can fight these two epidemics completely here at home. So let's look at how things have changed, or things have changed between the different states from the March to 2021 to maybe mid-2021 or 2021. And what you see here is that, again, white population compared and Asian compared to Black population have been the ones who have received the vaccine more compared to these two minority groups. Now, we talked about prevention, where I mentioned that we have to look at the population that is at high risk, and then try to give maybe PrEP. I mentioned PrEP, which is pre-exposure prophylaxis. These are just similar to HIV drugs, maybe in a different combination, that are given to individuals that are at risk for HIV acquisition, but then are negative to prevent them from getting the infection. So this is looking at data from as far back as 2015. this is the undergrad that I thought was very beautiful to show what the goal of this statement I'm trying to make here. So you have 62%, again, of white population in the United States. Estimated number of new infections coming from this population is 26. Total PrEP utilization by race, by white, is 73%. Let's look at the Black population, 13% in the United States, responsible for 44% of new infections in the United States, but only given 10% of the PrEP. And then, of course, Hispanic, responsible for 18 to 19% of the population in the United States, new infections responsible for 24% of them, and of course stands at 13% when it comes to PrEP. So the question we should be asking ourselves is, who are we giving the PrEP to? Is this the leading edge of the fire? Are white people the leading edge of the fire? We've shown that Blacks are the leading edge of the fire. We've shown that MSMs are the leading edge of the fire. So the question is, who are we giving the PrEP to? So we cannot really control the epidemic if we are not targeting the right population. That is the thing that I'm trying to say here. We cannot control the epidemic if we are not targeting the right population. So again, taking a look at this other study, HIV prevention field is not reaching most who could potentially benefit, especially African-American and Latinos. Again, from this study, it shows 44% of people who could potentially benefit, which is their contribution to the new HIV infections. They were only receiving 1% of the PrEP. This is a separate study. And then 25% who is looking at Latino, they're only receiving 33%, or 3%, not 33%, 3% of PrEP. So again, what this is showing is we are not targeting the right population. So the question that we should be asking ourselves is, so how do we then fight these two pandemics? That the two pandemics are actually very different pandemics, but have shown very similar patterns. With the pattern that they've shown is disparities in the health system. So both the disease reveal gaps in our healthcare system and the health status between Blacks, Hispanics, and Caucasians. That is a given. I also submit to you that MSMs carry the burden of all HIV infections, but the demographics have shifted from white MSMs in 2019 compared to way back then in 1981. The long-standing disparities in chronic disease contribute significantly to the disproportionate impact of both viruses in minority populations. And I will elaborate on this in just a minute. And then early diagnosis and treatment of any pandemics is important to prevent upward transmission. So, and this brings to mind the issues of health inequities as shown by social determinants of health. So what we are seeing is the health inequities that we have seen in our society, these disparities that we are seeing. So what is contributing to most of this? So and I want to read this verbatim, where the CDC actually defines social determinants of health as conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. So that is the working definition of social determinants of health. And in this schematic, you see here, they fall under 5 major categories, where you have education access and quality, you have healthcare access and quality, you have neighborhood and built environment, you have social and community context, and also you have economic stability. So when it comes to education access and quality, what we realize is that these minority populations that we've already looked at, whether it's the Black African Americans or Latinos, they have poor educational status, which leads to poor access to health information. If your educational background is already very poor, there is no way you're going to know where to look for the information that can help you when it comes to your health. When it comes to healthcare and quality, there is delay in treatment when it comes to African Americans and Latinos. As a matter of fact, listening to Dr. Beringa talk about this early in the morning, he mentioned that African Americans normally present to the clinics when they are at the advanced stage of the disease. It's the same thing here with HIV, where individuals actually present when they are already at the AIDS stage. Meanwhile, so it means it's taken them all these donkey years, or maybe 8 to 10 years before they are actually diagnosed with HIV. And by that time, they're already at the AIDS stage. So there is delay in the treatment. And then poorly managed care as well. So in the communities, maybe there are lack of qualified care providers from the minority communities. So one of the studies that I actually came across did mention that from 1908 to 2008, African Americans only contributed to about 2.5% of the total physicians in the United States. 2.5%, again, compared to their contribution to population, which is at 13%. Now, it was only after 2008 that they started increasing the recruitment of African Americans into medical school. And even as we speak, that percentage actually stands at about 5%. So you look at it, it's still very much less than the 13% that contributes to the population. And even with the Hispanic, it stands at about 5.6% or 5.7% compared to their 20% contribution to the population. So you see again that these communities actually lack qualified care providers in the minority population. The other thing that I want to talk about is trust. Again, when you look at trust, we have historical things that may actually cause individuals to not trust the healthcare system, whether it is the vaccination or whether it is the prep for HIV or whether it's the HIV treatment itself. The people might look at these things historically and say, okay, how do I trust this particular treatment compared to what happened in the minority communities in the past? And in this case, I may be citing something like the Tuskegee experiment, which most of us are all familiar with what happened. So we have to admit the past, deal with it, and then maybe address individuals who do not trust the system because of this historical context that they find ourselves or that we find ourselves. So poor, violent neighborhoods, we are looking at the environment here where individuals from minority populations tend to live in environments that are very poor, and they are violent neighborhoods, are crowded and multi-generational household. Take for instance, COVID-19, if you are living in a multi-generational household with many people and then maybe having elderly population here, the chances of passing the COVID from one person to another in that particular context becomes really high. That is the context that you find yourself, and then there's no way you can run away from it, whether it is stigma, discrimination, and so on and so forth. So people from minority backgrounds are always dealing with this. Is it a stigma that you are Black and gay? Is it a stigma? So that's a double negative for in that case if for an individual who is looking at the stigma. So all these things people have to deal with, and it does affect their health in significant ways that we have to, as a community, as a country, look for ways to address these issues. And when we look at social and community context, we're looking at mass incarceration. Blacks and Hispanic combined are responsible for 58% of the prison population. Blacks alone, or despite the fact that they are only 13% of the population, are actually responsible for 33% of the prison population. So that is very disproportionate. And what does that do? Not only that in the context of prison, if you put yourself in a situation that, first of all, makes makes it easy for you to acquire the infection for that matter, but also it creates an imbalance in the society. It creates an imbalance in the society where now you have the few Black men that are left behind. The ratio of female to male partnership becomes imbalanced. So it's that maybe a single man, we have maybe 3 or more girlfriends, and so on and so forth. So that imbalance in the society has also been shown to drive the epidemic in the United States. So there was one thing that China actually discovered early on in the epidemic that is very, very important. And I just want to mention here that early on, they discovered that at least 70% of people who died from COVID in China had at least one pre-existing condition or comorbid condition. So that is an important observation, because if you look here at home in the United States, what you will discover is that the majority chronic disease, you have 50% African American are responsible for cardiovascular disease, 33% hypertension. So African Americans and Hispanic populations have a higher rate of all major chronic health conditions and this had led to the disproportionate burden of severe COVID-19 disease and death among the minorities. So if you had that observation already made early on, and you are actually doing targeted response, so these communities must have been targeted, maybe first for the vaccination, right? Second for maybe testing and so on and so forth. But was that the case? Maybe not. If that was the case, maybe we couldn't have seen these disproportionate death rates and severe cases in the African Americans and Latino communities. So here comes what we call the health equity or health equality and health equity illustrated. Like in the case of the COVID-19, maybe one can argue that, well, they made vaccines available to everyone. They made vaccines available to everyone. That is in a system where we're looking at health equality, where everyone has the same opportunities. Everyone has been made available the COVID vaccine. In this case, for instance, too, everyone has been provided with something to stand on so that they can get that vaccine or that fruit from the tree and so on. But then guess what? Everybody is not of the same height as shown here. You know, even with that too, you know, some people will get it and some people may not get it. So this is where you bring in health equity, where everything has to be individualized based on the individual needs. Because now in this case, you're providing the individual with a stand that will actually help them plug the fruit, that will actually help them plug the fruit. And just like in the COVID cases, you have given we've made COVID vaccines available for everybody, but what about the timing? Do they actually have the time to take off work to go to get the vaccine? Or do we have alternative times that individuals can actually go get the vaccine? So if you are working from, let's say, 3 to, let's say, 8 to 5, for instance, Monday through Friday, and vaccines are only offered from 8 to 5, Monday through Friday, and you are working. So that means even if they make the vaccines available, there is no way you're going to be able to go there and get the vaccine. And most of these minority populations are actually, you know, those people who are at the front line, you know, what we call essential services, where they cannot just take off time or sit at work from home and take a minute from the break at home and go get a vaccine. So you have to individualize these opportunities and make it possible for people to go and get the vaccine. So health equality, no to that, health equity, highly welcome. So a public health plan for the United States, therefore, to fight the pandemic, again, revisiting the formula that I presented to you earlier, we are looking at diagnosing people who are HIV as early as possible. Not only that, focusing on the right population, looking at the South, which is heavily, which has the highest prevalence and new infections rates in the United States. Looking at the MSM community, which again has been shown to be highly prevalent with new infections, and then looking at the Black community, looking at individuals within the community or areas within the community that are contributing to these new HIV infections, and then diagnosing all those people to make sure that we know as early as possible those who are HIV positive. Then when it comes to treatment, you do the same thing. You treat people with HIV rapidly and effectively. Make sure that in all these individuals that you've already identified that are HIV positive, that they are actually taking their medications, make it possible for them to actually go to areas where they can actually get the medications. Don't have them travel maybe in the bus for maybe a couple of hours to go get the medications, because in that case, even if they do it 1 or 2 times, they're not going to be adherent because it's going to be difficult and it's not going to be sustainable. So one thing with the treatment too is that individuals have to be adherent to the treatment to see the benefits of the HIV medications. And then of course, prevent new HIV transmissions by using proven interventions. Again, we talked about the PrEP, which syringe services and programs. So these are very important measures that have to be put in place, and not only put in place looking at the population that will benefit from it the most if we actually have to bring this to an end. And then of course, respond quickly to the epidemic. So what I've shown you is that the science or scientists actually have a plan to make this work, right? The question is, do we have the political will to make it work? And I'll end there and take questions. read. I can't, it's too far.
Okay, so I will read the questions for you, and you can respond as you see fit. The first question comes from someone in the Q&A. This was a very insightful lecture. It seems that implicit bias and racial disparities exist in the American healthcare system, and Black communities are most affected. I'd like to know what are some of the current efforts in place to ensure health equity in order to drive down the inequalities that exist in healthcare.
Yeah, that's a very important question. And that's the question that I was trying to actually answer in the last slide when I talked about the public health response to dealing with the pandemic or the epidemic, which is shown here, which is diagnose all people, treat people, prevent new infections, and respond quickly. This is actually coming from, I copied this from the CDC, responding to the epidemic, and America's, I think it's titled America's effort to bring the epidemic to an end, and then making sure, they're actually trying to put this as a formula and targeting the new infections or the new infections in the communities that are affected the most. So the question is, like I said, the science is there that has been proven to work. The political will is what we need to see now that will make this happen. And from all indications, it looks like there is progress in that area. So it's just a matter of time before we see, okay, is it actually working? So we will have to give it a few years, with the new director that has been, charged with this responsibility to see how this happens. There's definitely an effort, concerted effort for that matter, to see to it that the minority populations actually receive the highest care possible. Again, with this health equity agenda, that is where everything is moving.
Okay, thank you so much. I have one quick question, and then we'll kind of go back and forth between the chat and the Q&A. This one is a very good question, so I just want to get your perspective on it. Dr. Constance Bailey wants to know, who is the better soccer player, you or Dr. Banton? No pressure, no pressure.
She is.
She is. Your honesty, we appreciate it. Let's see, our next question. In the beginning, you talked about the vaccination rates in the United States and other countries compared to the countries in Africa. In your opinion, do you attribute these low vaccination rates in Africa to low resources, or just the mistrust in vaccinations as a whole, like we see here in the United States?
That's a very good question too, and you cannot attribute something like this to just one thing. There is mistrust there. There is low resources. There are things that low resources to even manage the vaccines, for that matter. Most of these vaccines that we have here in the United States, for instance, these things have to be stored at what, -70, -80. If you're taking those particular vaccines to some of the regions in Africa, they cannot be properly stored. So they would, so handling the vaccines in those areas will not even be possible. So the lack of resources makes it possible for some of the things that you've seen. Again, the mistrust too. I have people actually call me to say, don't take those vaccines, don't take this vaccine. And it's even coming from sources that you would not even believe, from family members that I would say, you cannot take this vaccine. And even you try to convince them, you are trying to convince them not to take the vaccine, and they are trying to convince you not to take the vaccine. So it's something that is a double sword here, really, when we look at this thing. But definitely, both of those are applicable in this case.
Thank you for that response. Complacency and fatigue have been both blamed for the relaxation of COVID-19 response, as well as the AIDS and HIV issues. Do you think that is actually true, or are these ways to shift blame to the sick rather than fix the structural inequalities?
No, definitely we cannot shift the blame to the sick. when you look at efforts that have been made in the past, for instance, IDUs, way back then, injection drug users used to be the heavy drivers of the epidemic as well. But if you look at the reduction rates from their contribution, reduction as high as 93% actually, that means that if we do put a system in place that can take care of something, definitely it can work. So the question is, why can't we put the same effort that we put with the injection drug users and put it with maybe MSMs and put it with African Americans, or put it in the South, put it with the Hispanic population and see whether it works or not. So I think it's just, and if you look at, some of these things, some of these risk factors, whether it's white or black or Hispanic, maybe the risk factors are actually the same. But then when you look at, how they are treated, then they are treated differently. So that means that they have more benefits that can actually deal with that exposure differently. So I don't think we can shift the blame to individuals. I'm not saying that individual, maybe to an extent, people also have to take control of their lives. But again, there is a system in the society that makes it make it difficult for individuals to access some of these services and get treated or get treated with HIV, or prevent the acquisition of HIV for that matter. I stop sharing.
Thank you very much. We have two more questions. The racial disparities are telling, unfortunately, though not new. It seems that the most effective way to address these disparities is by addressing anti-Black racism. This is more than political will. Essentially, as long as white supremacy prevails, Black people and other minority communities will suffer. Do you agree with that thought?
I mean, like I said, you can never think that one thing will address some of these issues, and we are really diving into an area where I don't have that much data to support any of the things that I might say. But definitely, no one thing can address some of these things. Maybe taking that into consideration, that maybe one of the things that we have to pay attention to address some of these disparities that we see. But again, you have other things that we also have to put our focus on to make sure that we completely take care of the disparities that exist in our society. Now, so you mentioned that there was something I wanted to say, but anyway, if it comes to my mind, I'll bring it. We can go to the next question.
Okay. What activities would address the issues that you talked about with the regional COVID issues?
I don't get the question very well. Can you rephrase that?
If you were to recommend interventions or things that we could do in our geographic region to help, I guess, get people to be more comfortable in understanding why the vaccine protects them, what types of things would you recommend? Okay,
I see what you're saying. Now, I think one of the things I would say is that I did mention that mistrust and misunderstanding are some of the things that have affected minority populations or minority communities in the past, where an individual can come to you and ask you that, why do you think this is any different from some of the scientific experimentations that have happened in those minority communities in the past. And I can, we can talk about the details of the Tuskegee here, where we know that 399 Black men, were being experimented and not given the treatment that they actually needed for syphilis. And over the lifetime of this experiment from 1932 to actually 1972, 28 Black men died from the syphilis. 100 of them died from complications that resulted from the syphilis. 40 of their spouses actually died from the syphilis, and then 19 of their offsprings were contracted the syphilis congenitally. So you see here that there is a system, that actually dealt with this minority population unfairly. So the question is, how do you then convince them that, okay, this is actually different? that the vaccine here is actually different. So if we don't actually admit that part first, and then come up with maybe more technical ways, maybe it could be counseling, it could be a different way of approaching it and telling them that, okay, this is really an unfair thing that happened in the past. This is not how science is done nowadays. Maybe that was then when science was very premature and there were no ethical measures put in place when it comes to scientific knowledge. So things have evolved because of this particular type of things where they put the systems in place to make sure that those type of things cannot happen again. So, so that's one way to look at it.
Awesome, thank you. So our final question of the night, it's kind of a two-part question. What made you interested in the research that you chose as opposed to hepatitis, malaria, tuberculosis, any of the other, gamut of things that you could have chosen? Is the first part.
Yeah, so that is really a very good question. One of the things that I tried to share with you earlier when I showed you the book by Dr. Lemke, which talked about man is not God. And I said that, this is actually somebody who worked in the time where I was born, in the hospital, actually, where I was born and raised in that particular surrounding. So when the AIDS epidemic came around, we could see things that were happening with the AIDS, how families were displaced, how families were affected, how loved ones were suffering from this disease. And as a science student back then, it became I don't want to say a no-brainer, but it did further your curiosity, your curiosity as to how can you best contribute to this particular thing, not knowing that this was actually a huge task for the world to deal with, not to think of a single young boy from this West African country actually thinking that they can actually contribute to anything significantly to fighting the epidemic. But so that is where the first interest came from. And then of course, I stayed on course with my coursework, and then later got graduate training focusing just on that. And now here I am still working on the HIV. So that is where the love affair with the HIV virus started.
And an amazing job, completely amazing job that you've done in contributing to the field. The last question of the night before we let you go rest. An inquiring mind in the Q&A wants to know what are some of the CDC's preliminary predictions about the future of COVID? If you can share.
Oh boy. Again, like I said earlier, I don't really know what the CDC would say about that, but I can offer my own opinion about what I think about the future of COVID. And the very first thing I would say is that we will be fooling ourselves if we think that this is just going to go away. That's the first thing I would say. The second thing I would say is that if you are not vaccinated, please better go and get vaccinated, because now you are one of those individuals who is actually contributing to to making this worse. I would say that too, because if we don't get vaccinated, and then the virus has a chance to continue to mutate. If the virus continues to mutate, now we're dealing with the Delta variant, for instance, we're dealing with the Beta variant. God forbid this mutates to the extent where we have to deal now with a virus that is even more lethal than the variants that exist in the population today. And then even God forbid it develops mutations that actually evade the vaccines that we have today. So that means that if that happens, we have to now go again and start from scratch to start developing new vaccines to deal with the pandemic. So that is what I would say about COVID. Please get tested, get the vaccine, and continue to keep preventative measures. I have my mask somewhere, I just took it off.
Thank you so much for your candid and transparent responses to our audience's questions. We really appreciate all the information that you've shared tonight. And the floor is Dr. Banton to close us out.
Thank you so much.
Great. I want to thank Dr. Yufenyuy for that wonderful talk. Thank you so much for sharing your expertise with us, to the university and the local community. I'm sure we're all better because of it. And I want to thank the audience for staying with us. Thank you for joining us and supporting the African and African American Studies program. I want to thank all of our co-sponsors for the event earlier today and for this keynote lecture. And again, thanking Sunitra, Dr. Hughes for her wonderful work moderating the questions, and for the other Ms. Hughes, the program assistant for African and African American Studies, Dr. Constance Bailey, who has been the head of the committee organizing the fall lecture, Dr. Valandra, Dr. Hearn, Trish Starks, Dr. Worsma Mosley, and all of the members of the committee. I want to extend my thanks to you, and we'll soon get back to work again to consider who we'll bring next to campus, and we hope that you will join us in that endeavor. So thank you very much for joining us, and have a good evening.